Rheumatology lecture series. Today we have approach to spondyloarthritis and its management.
Thank you. Are we expecting more people or?
A lot of them are online.
I presume so. Yeah. Okay. Right. So thank you again. It's a pleasure to have these lecture series, especially from broad specialties, subspecialties rather. And I think we've covered like 4 lectures so far. And today, I presume, is the last one, where we're just dealing with spondyloarthritis approach and management, essentially driving home some points. So these are the objectives. So by the end of this lecture, you should be able to use correct terminology, but that's very important these days because everything is a mixture of spondyloarthritis as such is a broad term, which has a lot of diseases incorporated in itself. So you need to use the correct terminology for the group of diseases, understand the concepts of spondyloarthritis, recognize the cardinal symptoms, should know how to approach a patient with SpA, and get an overview of the treatment. And the most important thing, at least at this stage, would be learn when to seek help and to refer, right? That's the most important thing. So this is actually going back to 1976, the publication way back in 76, which clearly depicts the journey of a gentleman who was a Canadian paratrooper who presented in 1947 to the Sunnybrook Hospital in Toronto. And this has been his, pictures taken at 10 years intervals. So 47, he was seemingly normal. This was 57 after he was diagnosed to have spondyloarthritis then, or seronegative spondyloarthritis as it was called then. Then this was his stooping posture in 67, and then 72 again, he was bent quite a bit. And then you have another picture which I didn't put up, was actually post hip replacement, where he kind of, his stoop posture gets corrected a bit. So the outline would be, I just deal with concept of spondyloarthritis, approach to a patient with back pain, how to assess. So approach is different, assessment is different, extra-articular manifestations, and then treatment decisions and follow-up. So here we go. So spondyloarthritis are actually a bunch of terms, a bunch of diseases, which now they are kind of brought into a whole basket of immune-mediated inflammatory diseases. So when I call it IMID, it's basically a concept which came up after understanding of the pathophysiology, pathogenesis, of especially when you talk about the cells involved, the pathways involved. So as and when we understood them better, we came to know that there are a few pathways which are certainly, driven by a few cytokines, few cells in the immune system. And that's why we have this whole concept of IMID, which includes all the spondyloarthritis, if I were to put it that way, along with uveitis, IBD, a bit of depression. So if you look at all these things, you have the TNF inhibitors playing a cardinal role, and you do have IL-17s also coming up in a big way. So that's why they've, branched them into different things, although having a common basket of IMID, which is the concept. So if you look at spondyloarthritis, we know that it's an articular, can have articular as well as extra-articular manifestations. There is an association with MHC class 1 HLA-B27 allele, and there can be overlapping genetic association right across these diseases, as well as common clinical manifestations. Most of them have comorbidities, which is the main thing for most of which actually get overlooked oftentimes. Especially we are so worried about the joints and the other things about the patient that we overlook the comorbidities. Global prevalence, it's kind of sketchy because we don't have many studies coming up. At least there were not many studies previously. And the other thing is, this terminology keeps changing. So I don't know where to put each of these currently. So broadly, we can classify spondyloarthritis as axial and peripheral. It's very simple, right? Axial is mostly the axial skeleton, which includes your neck, your spine, the pelvis, and then you have peripheral spondyloarthritis. So in axial spondyloarthritis, you have something called, it used to be called ankylosing spondylitis. Since last year, again, it's kind of an evolving thing. So now people started thinking that we have the fantastic group of medicines called biologics, and we hardly see anybody who is ankylosed, strictly speaking. So now they've taken out the ankylosing spondylitis and just call it axial spondyloarthritis, just to take out that term of ankylosed, because that's not our aim, to get anybody ankylosed and call it ankylosing spondylitis. So we have axial spondyloarthritis, which is radiographic and non-radiographic. So that's the axial part. And then the peripheral part has a good amount of a bunch of diseases together, of which psoriatic arthritis is the most common one. You have reactive, you have IBD associated, undifferentiated, you have ERA, which few of them go on to juvenile SpA, because ERA can have a good course for a few patients, and some of them progress towards the SpA spectrum, which is generally known as juvenile onset spondyloarthritis. So axial spondyloarthritis is predominantly affecting axial and root joints. What I call root joints is actually the shoulders and the hips. And the onset has to be less than, well, nothing is absolute in medicine, but when you actually talk about axial spondyloarthritis, we generally talk about patients who have an onset or who had an onset less than 45 years. Patient could present maybe at 50, 60, but if the patient has had an onset after 45, the chances are less that it will end up being called an axial spondyloarthritis. Patient needs to have a chronic back pain, mostly inflammatory, but not essentially inflammatory. You don't need to have an inflammatory back pain. Now, over the years, again, like what I said, with the evolution of technology, with the evolution of imaging, we've got to understand this aspect a lot better. What used to be starting with X-rays way back in the 84s, which is the modified New York criteria, has shifted towards to MRI now, because we have a whole lot of early pickup of disease thanks to the MRI, and that's when we had this ACES criteria and the classification criteria, which came up in 2009. So because at this level, I think it's important to go through these radiographic grades, because this is actually what we fall back on for most of the OPD-based diagnosis still, right? So we have 4 grades, 1 to 4, and of course the 0, which is normal. We can see that. So if you were to see the changes, 0 is actually no changes, right? You can clearly visualize the sacroiliac joints over here. 1 is actually an iffy. We have a suspected changes, which essentially talks about these blurry margins, and the gap is normal. There are no erosions visible. So that is grade 1. Grade 2, you need to have at least a periarticular sclerosis, which is visualized here. This is the joint, and we see that there is a bit of a periarticular sclerosis, and that's important to call it a grade 2. And if you were to ask me on the right side, I still am doubtful about this grade, right? Because right looks normal to me, fairly normal, maybe a 1. But when you come to grade 3, we're talking about erosions, which actually lead on to widening of the space. So if you look at, if you were to compare these two, so this is grade 2 and this is grade 3, we note that there is a widening of the sacroiliac joint itself, right? So that is because of the erosions of either at the sacral side or the iliac side. So that leads to a widening, and 4 is probably the easiest among the lot because we have a ankylosed joint. So that is where the earlier classification was, which is still important, especially when you talk about peripheral hospitals, and because not everybody do have an access to MRIs, and even if you have an access, it takes a few weeks to months. I'm talking about peripheral hospitals. We're lucky to be here in CMC, where we can kind of get a date closer to where we want, and still closer if you have some contacts, right? So it's very difficult to get MRI based diagnosis always. So X-rays are always handy that way. But what the problem with X-rays is it takes at least 10 years. I mean, 7 to 10 years is the gap from delay from symptom to diagnosis. So we're losing about 7 years of precious time in treating the patient, and that is when people started looking at things where we need to have more sensitive methods to diagnose early, because the trajectory is totally different. You have a diagnostic paradigm where we have a bit of confusion with imaging, which one to use, radiographs or MRIs. But at the other side, if you look, the trajectory of molecules, what you have today in terms of treatment is absolutely fantastic, because it's just taken off for the past 20 years, and we have a fantastic group of medicines which can curtail the damage if detected early. So the problem is, once you reach grade 3 or grade 4, still you can kind of modify structural progression, but you can't really prevent because it's already happened. So if you ask me, the X-rays actually tells you what has happened, right? I mean, it's gone, it's what has happened, but MRIs tell you what is going to happen. So if you see an inflammatory lesion in MRI, you know that tomorrow that's going to be a structural lesion, that's going to be an erosion, so you need to act. So that's the time you need to act, and that's the importance of MRI. However, I'm not going to dwell into it because once I get there, it's another class in itself. So we'll just stick to the X-rays for now. So like everyone says, rheumatologists are slaves to classification criteria. Not really. We just follow, and I'll tell you the difference between these two. But for this thing, the whole purpose of this slide was to just show that what is the stem, like, so you have to have a person, let's call it a person, whoever it is, male, female, with a back pain of duration of at least 3 months. So you can wait for 3 months, nothing's going to happen, right? And you need to wait for 3 months in order to get the first stem of the classification criteria. So somebody has to have a back pain of at least 3 months at or before the age of 45, right? So 45 we did mention. So 45 is the cutoff, and 3 months is for the duration. And then we have two groups. One is the imaging group, and one you call it a clinical group. So what you see on the left side is the imaging group, which is the sacroiliitis group, or sacroiliitis part of the ACES classification criteria, which essentially for me is mostly MRI. So once you have MRI changes, of course you can have, so let's go back. I'm sorry, I forgot to mention, I'm just pulling it back. So we did go through these grade 2 and grade 3. So in order to call a person or diagnose spondyloarthritis according to the modified New York criteria, which is developed way back in the 84, you need to have bilateral grade 2 or at least a unilateral grade 3. You can have a unilateral grade 3 with the other side being 1 or 2, or you need to have bilateral grade 2, and 4, of course, it's a given, right? So a unilateral grade 3 is diagnostic, and a bilateral grade 2. So that's a minimal criteria. But for MRI, I'm not really, again, going to it. It just says that MRI should be suggestive of sacroiliitis. You need to have a number of definitions for that as well. So along with that, you need to have one SpA feature. But if you look at the clinical part, you need to have an HLA-B27 allele positive with 2 clinical features. And the clinical features, so with this, you have a pretty decent, I wouldn't say it's really good, but pretty decent sensitivity. But if you apply the imaging arm alone, what happens is your specificity increases. So it's not a good screening test, perhaps, but it's a good diagnostic test, right? So I'll just run through these SpA features because each of these have their own definitions. So inflammatory back pain, you need to have 4 of the following 5. Patient has to be less than 40. So earlier the classification criteria was 45. This is 40 years. Essentially bringing home the point that it has to be a young patient, right? You can't really think of somebody who is 50 above. It has to be an insidious onset because you have the other group which have an acute onset, which is, catastrophic, like you have a disc or, something, infarct. All these things can have an acute onset. Improvement with exercise is one of the major things. No improvement with rest and pain at night. We'll come into a bit more details into this as we go on, because that's very important to understand what exactly the pain feature is. The other important thing is the good response to NSAIDs is really important. Patient has to get at least between 24 to 48 hours of good response to NSAID, and the back pain is not present anymore or is much better. So that's one history which has to come through while searching through the symptoms. And of course, arthritis. So all these things, which are clinical features, arthritis, dactylitis, enthesitis, psoriasis, you need to have inflammatory bowel disease, anterior uveitis, can be past or present. The patient need not have at that point, but patient could have had any time in the past. Then you come into the family history, where it has to be a first or second degree relatives. Any of these IMIDs, like, AxSpA, can have psoriasis, uveitis, reactive, inflammatory bowel disease. So any IMID, inflammatory disease, can be there. And HLA-B27 has to be positive. Standard laboratory techniques. Most of our folks come with a flow cytometry, at least the folks from Bengal, but we do a PCR technique here, which is more specific. But for me, I generally don't really repeat, you're basically, thrashing another 5,000 on the patient. It's not really needed. If flow is positive, I generally take it as positive with the other features. And of course, you need to have an elevated CRP. And this is what I was talking about, the bilateral grade 2 to 4, like at least, so the minimal criterion is a bilateral 2. or a unilateral 3. So the other side can be any of these. So sacroiliitis or MRI, let's not go into it for now. So this actually is a really good figure, which I really love describing, because it reminds me of the college hill, right? So if you were to talk about the trek, so imagine this is a park where you have, this is the base of the college hill, and then we climb up, all the way up. So if you look at a disease per se, a person starts here, and as the altitude increases, this is actually inflammation and this is structural damage, right? So let's presume that. And then we take multiple routes to reach the top of the college hill. And this route generally goes, okay, just a bit of a climb, and then patient remains as a non-radiographic. So like what I mentioned, the non-radiographic aspect is more of a conceptual definition. It's not it's basically a continuum of the same disease and not two different diseases. Again, the reason is you have better sensitive methods to pick it up before it reaches the radiographic stage. So non-radiographic can be, few patients stay as non-radiographic AxSpA. So the yellow ones are non-radiographic, and the red ones, as you climb up, as the altitude increases, your structural progression increases. And when you reach the summit, you have a bamboo spine. So very few patients reach there, bamboo spine, even if not treated, although we know that it is a progressive disease. It does progress, but not to the level that everyone reaches the summit. So you do have patients who get here, start climbing. So that's like the structural damage starts accruing damage. And then so over here, you have some patients who remain with an advanced radiographic AxSpA. Very few go into the bamboo spine now. And some patients have a very few, patients do have a spontaneous remission. And so this is actually the natural course, which leads to either you're stuck somewhere here, or you need a quiescent disease course, or you have some of them, very few people have spontaneous remission, and at the same time, very few patients progress. And unfortunately, we don't have a comprehensive picture of, just pick up one person and do a test and figure out where he'll progress. Unfortunately, we haven't really reached there. We do have data, though, in which we learned that 15% of inflammatory back pain patients develop AxSpA. So no disease, you start some back pain, inflammatory pain, 15% of them may develop. And 3 to 5% of non-radiographic patients on placebo reach remission. So that's this part of it. So they just get stuck there. They have some structural damage, they just get stuck. 5 to 30% of non-radiographic guys just progress and develop AxSpA over the next 20 to 30. So here again, we understand that's a very slow process, and it all depends on where you intervene at different times. And 10% of AxSpA patients develop late complications. So this whole bunch of, bamboo spine or all these things hardly seen these days, but we know that there is a proportion which go into it. Coming back to this thing of classification diagnosis, very important to understand, because what is diagnosis and what is classification? If you look at classification, classification is for patients who already have a diagnosis. So you make a clinical diagnosis of axial spondyloarthritis, and of course, your classification, certain things do help you to diagnose, but that's not a strict, thing or scale you go by, because these are meant for clinical studies where you have a bunch of people who are diagnosed to have whatever disease, be it lupus, whatever you call it. So you've diagnosed the disease clinically, and then in order to have a homogeneous group of population for your clinical research, you need to classify them. And that's why you have a classification criteria. So here in AxSpA, at least, it's essentially not just a clinical feature, not just an X-ray, not just a labs, but it's an integrated process in which you take your clinical history, you go into the examination, labs, and imaging findings, all put together, you make a diagnosis of SpA, which may not fulfill the classification criteria often. Now, what is a pretest probability? That's actually really important, and it's not just for this thing. I always keep, emphasizing this, because it's not really strictly followed these days, because you send a bunch of investigations, you look at it and say, ANA is positive, now what do I do? So that just shows that you haven't really applied the pretest probability of that particular disease, right? And this is different for diseases. This is different in the context you are in. So if you're in a primary care setting, it's totally different, because you have a whole lot of patients coming with back pain. You send a HLA-B27, then few guys will be positive. Doesn't make any of them axial spondyloarthritis. But at the same time, a tertiary care setting, when I sit here or we sit here, patients are referred by physicians. So your pre-test probability in ordering a HLA-B27 may be different from a person. So again, it depends on how you think, right? If you think like a primary physician, you're still stuck there. But if you know that somebody is referred after a good amount of history taking, diagnosis, your pretest probability increases, right? So that's totally different from where you practice. And of course, it's basically a multidimensional process, and it kind of varies with levels of confidence. And you always reappraise the diagnosis. So it's not that once you make, of course, there are folks where you say, okay, fine. Somebody walks in, I say, hey, that's AxSpA. That's very easy. But nowadays, I don't hope to get such people because I want to get them early, right? So reappraisal is often important, especially for women, because they can have, I'm not really going there because that's another thing in itself, because there is a huge difference between patterns and presentations of men and women, right? So that's a different thing. So oftentimes we emphasize that women, when they have this thing, it's really difficult to diagnose AxSpA. Not that it's rare, it's common, especially non-radiographic is more common in women than in men. So it's not that it's rare, it's difficult, it's more difficult to diagnose. So you have a patient coming in, and this applies for all the rheumatological problems. You need to have a clean history. So we depend a lot on, that's the reason probably we sit with 30 patients and spend a whole day in OPDs, right? And oftentimes people understand it the other way around, like, what do you guys do till 6 in the evening seeing 20 patients? This is what we do. So you need to evaluate the patient very thoroughly, because that's where you get missed. So you need to have a physical evaluation. So I often say that if at the end of a history and a physical evaluation, you haven't reached a diagnosis, it's very rare that you will come up with something fantastic at the end of doing some 20 tests. At least you should know at which direction you're moving. If at the end of these two things, if you're not sure what needs to be the next route, you missed the boat already, right? Then you need to have laboratory techniques where it's, for SpA at least, is not really helpful. You do HLA-B27, it's negative, doesn't mean that the patient does not have. It's positive, doesn't mean that the patient has. So then you have to reappraise the whole thing. Then you do imaging, which could start with X-rays. But if you have a patient who clinically is very clear that the patient has AxSpA, please don't do an MRI. You're just wasting another 12,000. At least I'm talking about the setting in which we practice. It's not a universal truth. Every other hospital or somebody who can afford, certainly you go ahead and do, because you can always quantify structural progression, because that is what we're worried about, not the inflammatory nature. Because your patient walks in, I make a diagnosis, I don't need to do an X-ray or an MRI to see that the patient has AxSpA or not. Then you reappraise it again, because there are certain features in MRI which can be false positive. So it's always it's a continuum. Like, it doesn't stop with just making a diagnosis and say, hey, you have this, take this and get lost. It doesn't happen that way. Patient comes back, I may be wrong. But all I'm emphasizing here is you need to have a strong clinical suspicion to order the right test at the right time to get the right report, and synthesize everything together, not just to, put everything in tandem, just get a report and say, hey, what do I do with that? You really can't do much about it. So structural progression is the norm, and the patient just progresses if you don't act. So let's move on to pattern recognition. It's very important. So history, you need to have inflammatory back pain. One of the most important things for inflammatory back pain, of course, there are a few criteria, but most important of them I would consider is the second half of night is really important, because that's when your inflammatory cytokines start peaking, and then the patient starts having pain. So it's mostly around 2 to 3 a.m. the patient will complain. Well, they won't complain, you need to ask. Like, they won't say that 2 o'clock, you're lucky if they tell you, but it's the second half of the night they have more problem with. I'm reminded of Dr. Danda, who really used to teach us about this alternating buttock pain, which is not so much used these days, but that's again a very, very crucial history. And these are things which you need to ask patients, because these things patients don't really tell you. They tell you that they have back pain, it's more in the night, they have some stiffness, so all these things patient will tell you, but few things, the second half of the night is very crucial. Turning in bed around 3 o'clock, 4 o'clock, they get woken up while turning in bed. That's really important. Alternating buttock pain is really important. And of course, you need to have early morning stiffness of at least 30 to 45 minutes. Many of them do complain of like 5 to 10 minutes. I feel better. You walk on. So that's not the case. You need to have at least for 30 minutes. Anything beyond that is a plus. Good response to NSAIDs. We did go through it, and a positive history of SpA. So if you have these bunch of things in history itself, you know what direction you're into. Then on examination, you need to demonstrate restricted spinal movements, not always there. Peripheral arthritis, enthesitis, dactylitis, anterior uveitis, symptoms suggestive of IBD. If you have a patient complaining of that, not just any loose stools, but you need to have specific things. Other thing, what I'm again reminded of Danasa was he used to say, if you have a fistula, that's very classical. So if you have some classical features, please go ahead and do a colonoscopy. HLA-B27, I don't really do for all because it's like, again, we practice at a place where we need to balance the financial aspects also. So if you can tick all the boxes, it's very easy, but for the patient, it just takes off. I'd rather do an MRI or a B27 with an X-ray and just start the patient on something good with that money, what he has, than just spending whatever he has on investigations. And of course, your imaging, which could be MRI or X-rays. So this is, again, the possible screening tool, I would say. Chronic back pain, which need not be inflammatory in nature, but it has to be more than 3 months. First symptom, around 40 to 45. Let's put it that way. Inflammatory pain is quite sensitive. It's specific. Simple to apply because it's a yes or no, right? And about 1 out of 5 patients will have Axial SpA. So again, you just have a chance of 20% there, right? Sacroiliitis on imaging, if available, yes, not recommended for screening. I mean, not at a stage where, like what I mentioned, you need to be judicious with your investigations. HLA-B27, you can or may not. But chronic pain syndrome, whenever you talk about, not chronic pain, chronic back pain, we have kind of evolved this. I really like this, right? Actually, I look at myself, and this is how we have evolved. We started there, went pretty okay, started here, and then we're back to the computer. So this is one of the commonest causes of chronic pain, chronic back pain, or even chronic neck pain. So anybody walking with, so again, you are stuck there because, most of these guys will be 35, 40, they have neck pain, back pain, you're stuck again. So you need to be really judicious when you're taking a good history, spend some time taking some history if you have time. Not just stick away investigations and say, what do I do with them? So some features to differentiate. So duration, again, like what I said, up to 3 months. Mechanical can be acute or any time. Age of onset less than 40. Mechanical can be any age, mostly middle, and the age is actually decreasing these days. It's like, even 30 years, 25 years, 35 years, they do have mechanical back pain. Insidious in IBP, variable onset, maybe acute in MBP. Improvement with exercise is really important. No improvement with rest. So improvement with exercise, no improvement with rest is mostly IBP. Like what I said, pain at night, second half, with improvement after getting up and walking for some time. And the other one, you'll have immediate response to the pain while lying down because, you just stretch. Improvement with NSAIDs, the other one, you need not give NSAIDs. You can just get away with paracetamol or some physio. Well, of course, physio helps in the other one also. So you need to get a history of acute onset injury, lumbar sprain, myofascial pain, herniated disc, vertebral fractures, SI joint pain, need not be axial SpA always, remember. Let's go to something interesting. This is a gentleman I saw in the last OPD. In fact, yesterday he had come for a review. That's what I thought I should include him. He's a 44-year-old gentleman. He's a bowel drilling operator from close by. He's been having this mechanical neck pain for 11 years, right? And he's gone to several doctors. A lot of them have treated them with multiple medications. Low back pain, if you stress and ask that particular second half or all these things, he'll say associated stiffness and getting up from a sitting posture, but not really. He's okay lying down and getting up. No specific early morning stiffness at all. Has difficulty in turning in bed. So that's one thing which came up when I was questioning him. No pain or swelling over peripheral joints, no enthesitis, no dactylitis, at least in the history. He was a reformed chronic smoker. And the reason why he came in was he recently underwent a percutaneous procedure in Ranipet, and somebody thought that he may be having something more than that. So why don't you come to a rheumatologist? Not a diabetic, not a hypertensive. He's already 44, it's getting to 45, somewhere there. We'll come to that in a bit. So we just talk about how to approach. Let's talk on how to examine. So once you reach a diagnosis by clinical history, half the battle is won, right? And if you haven't, you lost half the battle. So that's where you are at this point. And your examination just adds to what you have to, come across with whatever you've gleaned from his history. If you haven't, then probably you lost it. And this is what we call the Bath Ankylosing Spondylitis Meteorology Index, where we look at few things which are really important. First is modified Schobers, and that's what we have over here. So you have the posterior superior iliac spine, which is close to the dimples of Venus, if you can make that out. Then you mark at 0.10 centimeter above that. Ask the patient to bend forward maximally as much as he can without bending his knees, right? And just measure the difference. So that is the pictorial representation of the modified Schobers. Then you do a lateral spine flexion, which is essentially looking at your lumbar movement, tragus to wall distance, intermalleolar distance, and cervical rotation. I'll just show you the pictures of all these things. So this is how a lateral spinal flexion is done. Two ways. Easiest would be this. Generally, what I do is ask the patient to stand up straight, not bending his knees, and just measure the difference, the distance from the tip of the middle finger all the way to the ground. Ask him to bend to the sides as much as he can without bending the knees again, and measure the difference between these two. Cervical rotation, here again, it's not possible in the OPD to have goniometric measurements, but generally, what is the normal cervical rotation? Rough guess. That's stuck beneath.
60.
Oh my goodness, some Men in Black kind of thing.
Lateral rotation.
Yeah, lateral rotation, how much can you go? It's about 90 degrees the max, generally. I mean, that depends on the age. Like, I can't go beyond. Like, again, depends on how good your vertebrae are. So anything beyond 70 is normal. And then we need to measure the tragus. And this is oftentimes a problem because when I say tragus, this is what I mean by tragus, not here. So most of them measure from here, but this is the tragus, and that's the wall distance. Patient has to, the chin should be parallel to the floor, and patient has to be right to the back. The heels should be touching on the wall, if you have a wall, but generally our examination setups is really difficult. So essentially, heels have to touch the wall, and patient will have to, the chin should be parallel to the floor. Intermalleolar distance, the preferred method is, lying down, but oftentimes what happens is the couch is against the wall, then you're stuck, like, you can only measure one side. So generally I ask the patient to stand and do the intermalleolar distance. Chest expansion is another thing. So these are so I just focus on the mild ones. So cervical rotation, like what I said, anything beyond 70 is normal. Tragus to wall distance, about 15 centimeters, rough cutoff. Lumbar side flexion, anything, beyond 10 centimeters normal. Lumbar flexion, which is Schobers, or modified Schobers, is around 5 centimeters. Anything less than that is abnormal. Intermalleolar distance is 100 centimeters. So that's what we generally talk about. I'll just skip through. It just essentially shows the variation of the different presentations in SpA population across the globe. So peripheral arthritis, generally we talk about 28 counts when you talk about rheumatoid, that because it doesn't include any of the joints in the lower limbs. And here, mind you, most of the people have problems in the lower limb. So for axial spondyloarthritis or any spondyloarthritis spectrum, especially psoriatic arthritis, you need to measure all the joints in the lower limb, which essentially means your hip, your knees, your metatarsal joint, your ankles, and then the MTPs, IP and DIP of the feet you can put together. But also upper limb is still okay because the patient is sitting, all you do is, and you're happy, patient is happy. But 66% of dactylitis, at least in patients with psoriasis, occur in the toes. So be careful to examine the toes, otherwise you miss the diagnosis, at least in AxSpA. Enthesitis, generally what we do is MACES for axial spondyloarthritis because it doesn't have much of, so this is MACES, first costochondral, these are all theory, you can always go back and check. MACES is predominantly axial, except for the Achilles tendon, which is common across these three evaluation methods, which is MACES, Maastricht Ankylosing Spondylitis Enthesitis Index. SPARC is Spondyloarthritis Research Consortium of Canada. method, and lead synthesitis index is mostly for psoriatic arthritis. So this is a combination of all the 29 sites. I wouldn't really encourage you to do all 29, but certainly you can do a 13 for axial spondyloarthritis because that is what really counts. That is the first costochondral, the seventh costochondral, the supraspinatus. You need to have the iliac crest, the ASIS, the PSIS, the fifth lumbar spinous process. So there are 13 sites for MACEs. At least that if you do, that should be good enough. Back to the examination of the gentleman we're talking about. His PP was okay. He had a clubbing, chronic smoker. Modified Chauvis was 4 centimeters. Cervical rotation was bilaterally less than 60 degrees. Could be because of his mechanical neck pain. Lateral spinal flexion was bilateral 6 centimeters. Tragus to wall distance was 12. He had a good hip joint. IMD was more than, intermalleolar distance was more than 100. Chest expansion was just about 5 centimeters. Absolutely nothing going on in the joints. However, there was a lateral epicondyle and right Achilles tendon insertion, which were tender. No dactylitis, no psoriasis. So this, if you're really interested, this is something which you can easily download on your phones. This is by the Assessment of Spondyloarthritis International Society, which is ASIS. They have an app which helps you to measure this disease activity. You just need to punch in whatever the patient says, and a CRP, you do get something to measure when the patient comes back, right? So otherwise you ask, hey, how are you doing? I'm good. That's not a valid way of asking. Extra-articular manifestation is always important, a bunch of them, acute anterior uveitis, psoriasis, UC, and Crohn's. So this is actually part of that IMID spectrum. Lungs, you can have restrictive lung disease, apical fibrosis. Obstructive sleep apnea is quite common. If you look at it in the normal population, I think it's more now. It's like 24%. It's more, but certainly more in patients with AxSpA, especially when you have a neck restriction. Heart is really important. You need to be on the lookout for aortic insufficiency. Not for all patients, again, you don't need to waste your time on that, but certainly this is something to be kept at the back of your mind that they do have extra-articular manifestations. And one thing, of course, kidneys, IgA nephropathy is quite common. It's not very uncommon, let's put it that way. You need to be careful there. Renal amyloidosis, rare. NSAID-induced nephropathy, yes, that's something to look into. And caudate vena is, again, something which is important. But beyond all these things, one of the major things which has been coming off late is depression. And if you look at actually the treatment regime of depression, MDD, they use TNF inhibitors. So we have the same, MDD is major depressive disorder, right? MDDs, there was a Nature paper in which they recommend the use of TNF inhibitors, which we graciously use in all our SpA patients if we can. So that's back to the X-ray of the gentleman. So look at this X-ray. A fair bit of degenerative process, but there is a syndesmophyte here. This is probably a degenerative process, and the straightening of the spine. So you can suspect, but this doesn't really help you. Look at his pelvis, pretty normal. I mean, like there's a bit of periarticular sclerosis here, a bit of mild narrowing of the right sacroiliac joint. Left seems to be, one look, it looks normal, right? I went ahead and did an MRI, and here it comes. So this is the STIR sequence where you can see bone marrow edema right across the sacrum, anterior portion, this one. And same thing, you have a few erosions at the mid portion of the SI joint over here at the iliac side. On the spine, we note that there are some corner lesions, inflammatory lesions over this one, over here. So this gentleman had a good going inflammatory, axial spondyloarthritis, which was actually missed for nearly 11 years of him just complaining of an neck pain. So this is very important to understand when to order what. This is certainly a given that if you have a patient like this, it may be worthwhile just getting an MRI done rather than going for an HLA-B27. If it's positive, yeah, so what? I mean, here at least I know that there are inflammatory lesions, so I need to hit them hard at this point because I don't want all the lesions to be at this stage and say that, hey, you lost the whole thing. So this is the point where you have to treat a patient because you can do quite a bit in not really getting to this stage, right? So risk factors for disease progression. So this is a baseline X-ray of a gentleman. And 2 years later, look at what has happened. So there was something happening here. There was a small syndesmophyte, which is actually fused here. So this is what we try to prevent as much as we can. And if we know the risk factors, presence of syndesmophytes at the baseline is one of the major risk factors for patient developing a progression of the structural lesions. Elevated inflammatory markers, be it ESR or CRP at the baseline, is a marker. Smoking is an important marker. So the other gentleman was a chronic smoker. He's a reformed now, but the process has already started. Low BMD and high disease activity score, let's put it that way, regardless of what you measure. And of course, mechanical stress like occupation, physical activity, twisting, all these things add to the structural progression. So the treatment, the goals of therapy is really important, because we need to understand the treatment is essentially to reduce inflammation and of course pain, bring a good physical function to the patient, improve quality of life. And when you talk about quality of life, it's not just pain. A lot of patients have fatigue. That's one of the very common symptoms, more so if you're dealing with a lupus patient. So a lupus patient comes back to you complaining of fatigue. Make sure that you do a thorough investigation on that. I'm skipping the main point, but fatigue is one of the very common features of a lupus patient. So not so much for AxSpA, but certainly patient will complain of fatigue. Essentially, it talks about inflammatory process, participation in meaningful life activities, work capability, reduce structural progression. That's important for me, because that is what leads to long-term damage. Improve associated conditions like uveitis. So it's always, so nowadays, whenever a patient comes to me, we have a group which we work together. I work with Derm1 folks, then Oftal, Dr. Smitha is there, IBD, Dr. AJ is there. So we kind of work together. So whenever a patient comes, we make sure that, at least the patient goes a full circle as much as he or she can, because it's very important to diagnose them early. Again, uveitis need not, most of them do have acute anterior uveitis, but not always. They can have past history, which may not be evident when you take a history, but if you examine, they can give you a past history. Treat comorbidities, very important, and reduce their impact, and long-term prolong their life expectancy is something which we always strive for. So this is something unique in India. So all these literature is basically meant for the Western world, where you have a good number of molecules coming out every day. You have insurance or the government to pay for. We neither have insurance nor the government. Patient has to sell his land to come here just to get an HLA-B27, and he'll say, oops, I'm done. So what do you do next? So you have beliefs and perceptions. Patient will have their own ways to drive you to a particular angle. Don't get carried away. Budget for health probably is the least of the concerns for all of us. In fact, infections, TB is a major problem for all our patients. And this is, I'll just come to it, cost of drugs, at least for, and methotrexate and sulfasalazine, yes, we used to play around with these drugs for quite a bit. Doesn't really help in terms of structural progression, but yes, it does help somewhere. We don't have evidence, but again, no evidence doesn't mean that it doesn't work. Compliance, how long to use is the main thing. And the other thing, what we talk about, the current molecules, what we have in India are all intended copies. There are not biosimilars. So there's a huge difference between, well, not a huge, but definitely there is a difference between biosimilars, which are available in the Western world, which essentially goes to the EMA or US FDA approval. So that's the difference, I mean, in simple words, right? You have a primary, secondary, tertiary, quaternary, these are all proteins, right? So you have these protein molecules. The structures differ. So it's mostly, essentially, it's the tertiary and quaternary things which differ. But generally, biosimilars are those which have got licensing from US FDA or EMA. None of our guys, or none of our companies who produce these things. Adalimumab is one of the most things. Every Tom, Dick, and Harry has his own brand of adalimumab, but none of these, doesn't mean that they're bad. But what I'm saying is we still only reached that level. So physiotherapy is, not to really dwell on this slide, physiotherapy is very important. We have a fantastic department. Please make sure that the patients go through them at least once. They'll give them a copy of things to do. They take a Xerox and just keep it with them. Generally, when I talk about physiotherapy, it's like, haan, doctor sahab, aayega karega. The aayega karega business doesn't help, because most of them think that somebody should come home and make or do a physiotherapy on them and walk away. So, the only thing with that is the person who comes in makes money and the patient is left high and dry. So encourage the patient to do physiotherapy as much as they or she can or he can. That's very important. Medications available for AxSpA in India, we have NSAIDs and conventional DMARDs. We have TNF inhibitors, which by far we have 4 of the 5 molecules what we have. We have etanercept, infliximab, adalimumab, golimumab. IL-17 inhibitors, we have secukinumab. Ixekizumab, as of today, is not recognized for use in India for AxSpA. It is mostly for PSA, but it is a well-known molecule overseas, which has been approved both by FDA and EMA for use in AxSpA. And the most favorite of the lot, which happens to be tofacitinib, widely available, being used as multivitamins. I caution you not to use that because not as multivitamins, because that's what most of the patients come with. So most of them have a prescription of tofacitinib when they come with, and that is quite dangerous because most of them are given by orthopedicians who don't screen them for tuberculosis. Recommendations: assessment, PROs, clinical findings, laboratory treatment to be individualized is very important. Not one size fits all. Be always cautious. Patient has or will have their own needs, so cater your treatment plans accordingly. Treatment guideline should be a predefined. You need to have a predefined target. You can't just keep treating the patient and say, "Ha, theek hai, chalta hai." So you need to have a target, and you need to, just like your diabetes, your hypertension, you have a target, keep a target and follow that. NSAID should be the first line, use with caution. Glucocorticoids, I wouldn't really generally advise. As long as you use intra-articular, that's pretty okay, but long-term systemic steroid is a strict no, especially when you know that that can cause osteoporosis. And this guy sitting there already has a risk of developing osteoporosis. So be careful there. Recurrent uveitis or active IBD, you need to be switching to, as much as you can to TNFIs, psoriasis to IL-17. And sustained remission is actually when you talk about tapering. When you talk about tapering, doesn't mean that you reduce the dose. I'm talking about spacing as much as we can. So how to treat, essentially stop smoking. You try with NSAIDs, they don't work for 2 to 4 weeks. You switch to phase 2. There's a phase 1 which just got cut off, or unless I missed it here. No. So phase 2 is if you have a lot of peripheral symptoms, you can of course go in for a short course of local steroids, mostly for dactylitis. I don't really recommend because most of these patients have psoriasis or psoriatic arthritis. They have comorbidities. So always have comorbidities at the back of your mind. It's very important for a patient of spondyloarthritis, be it axial base, PSA, reactive, whatever. If contraindicated or lack of efficacy, you switch to your biologic. We do have a good number of them, starting from 5,000 for adalimumab, goes all the way to 8,000. 2 shots a month will be between 10,000 to 16,000. You have IL-17 inhibitor, which costs around 11,000 a month. So that's what happened. Now I understand. So phase 1, you have a clinical diagnosis. You start NSAID and physiotherapy. The most important thing is education. Unless you educate the patient and tell them that this is a lifelong disease, you have to stick with it. You have to be consistent with it. Generally, when they ask me, how long should I visit you? I know it may be a cheeky answer, but then generally I say either I go first or you go first. So that's where we end. Like in rheumatology, I don't know whether it's a good or bad thing, but you're stuck for life, right? So it's a lifelong relationship what we build. And at this, so I'm back to there's something which happened here. Okay, let's go. So physiotherapy, we start methotrexate for a few patients who have peripheral arthritis, but this should be over here when phase 2, actually phase 3, let's put there. There's no phase 3, something happened in the slides. So essentially, okay, let's take it this way. So peripheral arthritis, start on methotrexate, follow the patient for 3 to 4 months. And if the patient doesn't have any response, you consider switching to a tofacitinib is really cheap. In fact, it's cheaper than methotrexate and sulfasalazine put together. It works out around 1,200 odd every month, which is really cheap. But be cautious when starting tofacitinib because you need to do a TB test and all these things. Education, yes. And then, so methotrexate and sulfasalazine, actually, they are a good surrogate to NSAID because most of our patients go back and they don't see you for the next 3 to 4 months. You don't want them to, straight away go to Ranipet and see a nephrologist and then come to you. So be cautious of, CIN, which can develop with NSAID. So and that's the reason why we generally, again, Nandisa used to tell us like methotrexate and sulfasalazine are like safe NSAIDs because the action is almost the same. It's all COX pathway. So these two medicines can be given. Of course, you need to monitor methotrexate. So all these things have to be given for about 3 to 4 months, maybe 6 months. Patient may come back with saying that, I've got good improvement to continue. No harm in switching, but no necessity in switching. But if the patient is not really getting there where you really want the treatment target to be, you switch. So follow-up can be only when you do active measurements, like what I mentioned. All you need is just download that app. It's really helpful. You need to have a buzz diet because these are not really absolute numbers, but it gives you some ideas. So you feel happy, patient feels happy. Itna se itna ho gaya. He feels happy, he feels encouraged to take the medicines. So that way you can take it forward. Once in 3 to 6 months initially, once in low disease activity, once in 6 months, or even once in a year. I have patients coming once in a year from Bangladesh, fairly doing well. Consider spacing DMARDs after a year, maybe, once they're absolutely fine. Yeah, and spacing again, not the dose, not to stop, but to make it like space it out. Like maybe patient was taking once a month, try taking to once every 6 weeks, 8 weeks, and beyond. Watch out for comorbidities and complications, very important. Osteoporosis assessment, I do it the first time, not for all because most of them are young, but if the disease is really active and if you have no intentions to control it at the earliest, please do a DEXA. At least you treat that, right? And push the patient for NSAIDs. Treatment of complications is very important, and that can't happen till you look for complications. So you look for complications. If you have any, please treat. So in conclusion, diagnose early, treat aggressively, and taper gradually, but spacing out. That's the mantra, right? So diagnose early, treat very aggressively at the initial stage so that you reduce the damage. And then once you get there, you can space it out. Aim of treatment should be delay or reduce structural progression and thus increase your function level. Patient education is paramount to successful treatment. Always remember that. The way you talk, the way you convince the patient that it is a lifelong disease, it's up to you. Physical examination is really important, including all the clinical domains, not just the spine. You have to look for dactylitis. Unless you look, you won't find. Look out for complications of the disease, more in patients with comorbidities. And shared decision is always helpful because the patient always feels that, okay, he was also party to that decision rather than, doctor told me, take this, and that's all. I don't know why, what. So explain to the patient, that will help in fact having a long-term relationship, both in terms of disease control as well as your relationship with the patient. Thank you very much, and happy to take questions. Questions online?
So that man that you had said, most probably then the coronary artery disease might have been because of the underlying inflammation, because he was not a diabetic, not a...
Been a smoker for 15 years.
At 45.
Probably, yes. I mean, this is not something which happened yesterday. I'm pretty sure it's been going on for a good going 10 to 15 years.
So how often do we need to screen, and what do we need to screen for in terms of comorbidities for these patients, like diabetes?
Yeah. So there are two ways to answer it. One is the ideal answer, and the other one is the practical answer, right? So you don't, of course, age is a major thing for all these patients, and you don't get patients who are really old. Most of them will be 30, 40. If you have other comorbidities like overweight, diabetes, yes, it's a given that you have to screen. But if the patient doesn't have anything, your CRP may be a good marker because at least I'm not for axial SpA, but for psoriatic patients, you need not have a good CRP. CRP may be normal at times, but I wouldn't really a lipid profile, which anyway you'll have to do for your. So these little things, and if you have a patient who is more on the obese side, a bit of liver, fatty liver, MASLD, whatever, certainly go in for a lipid profile. If that's really high, you can screen maybe. ECG is not going to help. It's not an acute thing. It's a chronic thing. So I think that's something which I would do. but idealistic way would be to at least get an echo done if, but that again doesn't really show you what it is. I think a fasting lipid profile may be a good profile. And the other thing is encourage them for exercise, because that's really important. A1C lipid profile, these things you can do in an OPD basis. PCG is not, unless it's an acute, of course, unless, I don't think it's a good screening tool as such for all the patients, if you were to ask. I think a lipid profile and A1C may be something to go forward with.
That's ESRC everything ruled out.
No, never. You can have a negative CRP and ESR, because if most of them do have a fair amount of inflammation, it's not that, it's very seldom that you get someone who is absolutely stuck, as in, like, just structural lesions and no inflammatory lesions. So in those patients, yes, you may be lucky enough to find somewhere between like 7, 8, 9, somewhere there. But if you have a good going inflammation, it can go all the way to, in fact, hundreds. So that's the difference between Axial SpA and PSA, where you can have a normal CRP for a PSA as opposed to Axial SpA. Axial SpA inflammation can shoot it up way beyond 100. But at the same time, you can have a patient with a normal CRP. Doesn't mean that he doesn't have the disease.
Building on your comments on exercise and inflammatory back pain, does exercise also delay the progression?
That's a good question. Short answer is yes, to a certain extent, but just exercise alone is not going to help. It's just that when you give a treatment, we generally tell them to be mobile, because the more static you are, and again, it depends on what you mean by exercise. Like rigorous exercise is a strict no, especially when you have a structural progression ongoing. But if you have somebody who is totally, sedentary, you can ask the patient to move. But that's not by itself a treatment for structural progression. So definitely all these things add up. It's not just something that, this leads to this, but certainly physiotherapy, yes, for each joint, range of movements and all. But again, if you overdo, there is a risk of syndesmophyte and structural progression there.
So who do you decide who to give methotrexate or adalimumab?
If you ask me, again, ideal answer and practical answer. Somebody who can afford adalimumab, certainly yes. Somebody who can't. But like what I said, TOFA is a very good option, what we have. But we need to be very careful whom to give TOFA, because although the oral surveillance data showed about a good going, thrombosis risk with TOFA, we need to be mindful when we give the patient. But the good thing is most of these patients will be young folks. So if you don't have a cardiovascular risk in the background, is maybe an ideal person, as long as you rule out tuberculosis. So that's another thing. And a lot of these patients do have, rifampicin resistant bug. So those things are quite common. So in the setting, TOFA may be a good alternative. But if the patient can afford, certainly TNF inhibitors can be given. So if somebody can afford to shell out 10,000 a month or maybe 12,000 a month, I would certainly go to adalimumab. But yeah, TOFA is widely available, but at the same time, you should be wary of the complications which can be a problem. So patients who have cardiac risk factors, obesity, because obesity, the problem is you are at a risk factor for MASLD. And then you give, there'll be some fatty liver, you give TOFA, that again ups your triglycerides. So everything is in that spectrum. So you need to be careful there. Nothing online, so shall we call it a day? Thank you very much. think you should start with lunch and have more people come.